Morning everyone. So this is going to be a case-based interaction, and I hope this is going to be a cakewalk session considering the brilliant talk that we've had in the last 1 hour, and there's also bound to be some overlapping information. So for everyone here, there are 4 images on the slide, A, B, C and D. So can anyone point out, oops, yeah, A, B, C and D. So can anyone point out which among this is melanoma? Any guesses? C is a melanoma. Why? Because it is darkly pigmented. A has feeder vessels, there are large dilated vessels. B has some amount of variegated pigmentation. C is very dark. And D, there is multiple lesion. But because of the darker pigmentation, do you think C is the malignant melanoma? Could be A also. Okay, so for all those who thought and maybe answered and I didn't hear, all the 4 images are of conjunctival nevus. So the image A, you see there are feeder vessels, but feeder vessel is present in about 1/3 of the conjunctival nevi. So are intrinsic vessels, which are again present in 1/3 of the nevi. In B, there is variegated pigmentation, but this is commonly seen in lightly pigmented nevus. There are some spots of darkly pigmented stains. The C, in darkly skinned individuals, deep pigmentation is common, and especially this is seen in our Indian population. And the last one, there are multiple lesions is seen in about 5% individuals, bilateral lesion is seen in about 1% individuals. So none of these characteristics must be taken as something that belongs to malignant melanoma. But one thing that can distinguish a nevus from a melanoma is presence of microcysts, which was already shown by Dr. Vikas Menon. So these microcysts are present in about 63% of the melanocytic nevus, as opposed to only about less than 5% in melanoma. So along with other features like age, history, thickness, size and number of feeder and intrinsic vessels, and the presence of cysts, you can distinguish between a nevus and a melanoma. So applying these features on this elderly patient who gives history of 2 times prior excision biopsy, and this lesion has recurred for the 3rd time. What do you think this lesion is? Correct. So the elderly patient, there is a positive history. The lesion is quite thick. The size and the number of feeder vessels and the intrinsic vessels is quite high. So this is quite likely pointing towards a conjunctival melanoma. But of course, not all melanoma are so thick, and they don't come with the positive history. Like in these 2 patients, they don't give any history. They just notice something dark growing along the lower part of their eye, and it is a completely flat lesion. Okay, so not all melanomas are thick. So this is one intelligent patient who came with series of photographs from his childhood. He said that he had this one particular dark spot in his eye, which was almost right from the time of birth. During his early teen years, the lesion grew slightly bigger. During adulthood, the color changed from dark black, brownish to slightly reddish in color. So what do you think is happening here? What is the complete diagnosis for this intelligent patient who gives a good history? Growing nevus into what? He also says there's a change of color from blackish to reddish. So what has happened? So the lesion, this is the lesion. So what do you think has happened now? So the diagnosis is conjunctival melanoma arising from a pre-existing nevus. So this patient had nevus in his childhood, which grew with his age, and it has turned into a malignant melanoma. So how do you manage all these conjunctival nevus? Obviously, topical medicine like mitomycin interferon does not work in melanocytic lesions. Observation is a definite thing in melanocytic nevus. Surgery is indicated when there is growth, or there's a large nevus in atypical location, or when the patient wants cosmesis. Like this patient has stable nevus, there's no corneal invasion, there are no symptoms, but she wanted it for cosmesis. So a wide excision biopsy was done, cryotherapy applied to the resected conjunctival edges, ocular surface reconstruction done with amniotic membrane, and the patient showed excellent cosmesis post-operatively. How do you manage malignant melanoma? That Dr. Honavar has already dealt with. Observation and topical medicine is an absolute no-no, and melanoma is mainly a surgical disease, so wide excisional biopsy followed by ocular surface reconstruction. But one thing you must remember is in all melanoma, you must do a systemic evaluation, because melanomas of the eye have a propensity to spread to the regional lymph nodes and to the brain, liver, and lungs. So sentinel lymph node biopsy along with a PET scan is necessary periodically to, for a good systemic evaluation. So again, there is no doubt this is a conjunctival melanoma, but what you see is it is not in the bulbar conjunctiva, it's in the tarsal conjunctiva of the upper lid. So how do you want to manage this patient? Do you want to do again a wide excisional biopsy, cryotherapy, and ocular surface reconstruction? Of course, that's a definite possibility, but stripping the conjunctiva over the tarsus is a difficult task. Okay, and then reconstructing the thing is all the more a bigger task, and it is usually not a kind thing to do to the cornea. It can cause a lot of irritation. So the best thing in this particular case is to probably do a full thickness dissection, including the eyelid, do an eyelid reconstruction, and the patient is forever grateful to you. So what is this patient? This is an elderly patient who has noticed that there was some pigmentation in his early adulthood, not present at the time of birth. The pigmentation gradually grew darker, bigger, and this is his presentation. So what is his complete diagnosis? Pigmentation not present at birth. So definitely not a nevus. Pigmentation came during adulthood. So what kind of pigmentation is that? Correct. The nodular melanoma is correct, but from a pre-existing primary acquired melanosis. So there was some pigmentation which has gotten darker and bigger with age. So this is conjunctival melanoma arising from pre-existing PAM. So this patient also had some amount of orbital extension. So he was offered orbital exenteration, and the patient was very happy with this. So what kind of lesion is this? Pinkish lesion? Correct, lymphoma. So what do you want to do? How do you want to assess this, and how do you want to go about it? Lymphoma is fine, but you can see the anterior border is at the limbus. What about the posterior border? Yeah, so there is no discernible posterior border clinically, so your next step should always be imaging. So on imaging, what do you see? Okay, now I'm pointing it out. What do you see? There is some amount of thickening along the superior rectus. So this particular lymphoma is not just conjunctival lymphoma, but it is an orbital lymphoma. And on systemic evaluation, which includes PET scan and bone marrow biopsy, the patient had positive mediastinal and retroperitoneal lymph nodes. So this patient is not just orbital lymphoma, but he has systemic lymphoma. So how is systemic lymphoma treated? By systemic chemo. 1 minute? Conclude in 1 minute? Okay, I'm going to have to skip a lot of slides. So anyway, so the systemic lymphoma is treated with systemic chemotherapy, and for the orbital part, you give orbital radiation. So this patient is again a case of lymphoma. Next step is to do imaging. On imaging, you see there is thickening along the lateral rectus, but on systemic evaluation, he did not have systemic involvement. So this patient is spared of systemic chemotherapy, and for his orbital lymphoma, orbital radiation can be given. This is again a lymphoma, but as you can see, it is a well circumscribed lesion with all the borders quite visible, and on imaging he did not have any orbital part, systemic evaluation, no systemic involvement. So such patients are treated just with conjunctival resection and then observation periodically. So there are a lot more slides on OSSN, but I guess I'll have to conclude here. But I'm sure Dr. Honavar has taught you a lot on OSSN, so I guess this can be skipped. Thank you so much.
Thank you all for your presence. If you have any pressing questions, you can ask now because the next session begins in 5 minutes. Any questions to any of the speakers?
How frequently do you give interferon injections?
How frequently do I give interferon injection? I give interferon injection in patients who are not compliant to topical therapy where we have to treat it. Because it's a monitored dose, or in patients who have extensive ocular surface involvement, like I showed you, palpebral and bulboconjunctival involvement, which are inoperable. How frequent? The frequency of injection, every 3 weekly.
Like the problem with interferon is you have to keep it in a cold chain. That's a big hurdle.
Injection?
No, the topical
drops, of course.
So that becomes very difficult for the patient compliance.
Then you can use 5-fluorouracil. Mitomycin is, it causes more symptoms.
More symptoms, yes.
5-FU is a compromise between interferon and mitomycin.
Okay.